Hi everyone, I am Ray Camacho, and this presentation is based on tuberculosis. Hope you enjoy. A typical patient presentation, for example, could be of a 15-year-old male who went to his primary care physician with symptoms that include frequent cough, weight loss, fatigue, and night sweats for 4 months. 2 months ago, he was treated for bronchitis that was unresolved. His CXR showed extensive right upper lobe infiltrates and multiple cavitary lesions. Tuberculosis was suspected, and a tuberculin skin test was placed and read at a 25 millimeter in duration. Patient was referred to a pediatric pulmonologist. The pulmonologist collected sputum specimens that were positive with numerous acid-fast bacilli. The etiology of tuberculosis. Tuberculosis is an infectious disease caused by bacteria of the Mycobacterium tuberculosis. Similar disease occasionally result from the closely related Mycobacteria bovis, Mycobacteria africanum, and Mycobacteria microti, which together with Mycobacteria tuberculosis are known as the Mycobacterium tuberculosis complex. These bacteria are roach-shaped bacteria that spread mostly through airborne droplets or dust microparticles of dry sputum. Some background on tuberculosis. It causes a primary, often asymptomatic infection, followed by latent infection, and in a few patients, an active disease phase. About one fourth of the world's population is infected with tuberculosis, and about 50 million have active disease at a given time. Tuberculosis is a leading infectious cause of morbidity and mortality in adults worldwide, killing about 1.7 million people in 2016, most of them in low and middle income countries. Active disease is much more likely in patients with impaired immunity, particularly those with HIV infection. Risk factors of tuberculosis. Persons who have been recently infected with tuberculosis bacteria can be people who have immigrated from areas of the world with high rates of tuberculosis. Groups with high rates of tuberculosis transmission, such as homeless persons, injection drug users, and persons with HIV infection. Also, persons with medical conditions that compromise the immune system. These medical conditions are HIV infection, diabetes mellitus, severe kidney disease, head and neck cancer. As I mentioned earlier, tuberculosis occurs in three stages, starting with primary infection, then latent infection, or in some cases, active infection. Now, I would like to discuss how this bacteria likes to infiltrate the body. First, the bacteria is inhaled. The majority of the bacteria will become lodged in the upper respiratory tract, namely the nose and throat, where their survival is difficult. Some of the small particles, though, will make it into the lungs and alveoli, where infection sets in and where they build a house. The bacteria can also be ingested if it's not through the respiratory tract. Secondly, the bacteria likes to multiply. In the alveoli, the bacteria are engulfed by unactivated macrophages. Macrophages are white blood cells presented with tissues, where they multiply until the macrophages burst. The Mycobacterium tuberculosis replicates very slowly, once every 24 hours, and takes up to 1 month to form a colony. In the third stage, there is a T cell activation. In this T cell activation, there is cells that are called dendritic cells. These cells detect foreign substances entering the body. They engulf them, process them into small molecular fragments with potential antigens, and bring them to the lymph nodes where they present the antigens to certain white blood cells called T cells. If the T cell has a specific receptor for the presented antigen, it will become activated to release potent molecules such as interferon gamma and tumor necrosis factor, which in turn stimulates macrophages and other T cells to produce a cell-mediated response against the bacteria carrying these antigens. In the fourth stage, there's a tubercle formation. The T cell returns to the site of infection through the bloodstream, where they contribute to the formation of a tubercle or granuloma. The tuberculosis tubercle is made up of a core of infected macrophages, a surrounding ring of foamy macrophages, and an outside ring of T cells, all enveloped in a fibrous shell. In some cases, an individual's immune system is unable to defend against the bacteria by creating a tubercle to isolate it. In the granuloma, the bacteria are inactive, and the case of tuberculosis is considered to be latent. The bacteria are contained in the granuloma until the immune system is weakened, breaking down the outer ring of the tubercle, releasing the bacteria inside. In the fifth stage, there is cavitation and tubercle breakdown. In some cases, the damaged cells at the center of the granuloma liquefy. The bacteria grow well in this liquid, multiplying outside of macrophages. Their typical host, as they multiply, the tubercle enlarges. This can cause nearby tissue in the lungs to die and rupture, forming a cavity or the tubercle to burst, spreading bacteria further around the lungs or the body. Next, on the pathophysiology of tuberculosis, with primary infection, it requires inhalation of particles small enough to traverse the upper respiratory defenses and deposit deep in the lung, usually in the subpleural air spaces of the middle or lower lobes, as the alveoli. To initiate infection, Mycobacterium tuberculosis bacilli must be ingested by alveolar macrophages, causing a focal pneumonitis. In the early weeks of infection, some infected macrophages migrate to the regional lymph nodes, where they access the bloodstream. Furthermore, on the pathophysiology of tuberculosis, in Latent infection, about 95% of cases, after about 3 weeks of uninhibited growth, the immune system suppresses bacillary replication, usually before symptoms or signs develop. Foci or bacilli in the lungs or other sites resolve into epithelial cell granulomas, which may have caseous and necrotic centers. The tuberculin skin test and interferon gamma release blood assays become positive during the latent stage of infection. Finally, in active disease of tuberculosis, healthy people who are infected with tuberculosis have about a 5 to 10% lifetime risk of developing active disease. In 50 to 80% of those who develop active disease, tuberculosis reactivates within the first 2 years. But it can also occur decades later. Any organ initially seeded may become a site of reactivation, but reactivation occurs most often in the lung apices. Conditions that impair cellular immunity significantly facilitate reactivation as well. Symptoms in active pulmonary tuberculosis, even moderate or severe disease, includes patients which may have no symptoms, along with anorexia, fatigue, and weight loss, which develop gradually over several weeks. More specific symptoms include coughing, which can become more productive as the disease progresses. Hemoptysis occurs only with cavitary tuberculosis. Low-grade fever is common but not invariable. Drenching night sweats are a classic symptom. Dyspnea may result from lung parenchymal damage, spontaneous pneumothorax, or pleural tuberculosis with effusion. With HIV co-infection, patients are more likely to have symptoms of extrapulmonary or disseminated disease. Pulmonary tuberculosis is often suspected based on one of the following diagnosis: chest x-rays taken while evaluating respiratory systems, which include coughing lasting 3 weeks, hemoptytosis, chest pain, dyspnea, and unexplained illness, fever of unknown origin, or a positive tuberculin skin test. They can also test for acid fest stain and culture of sputum. And then they also have something called the tuberculin skin test, which I have mentioned earlier, which is a test that is done by putting a small amount of tuberculosis protein, in this case an antigen, under the top layer of skin on your inner forearm. If you have ever been exposed to the tuberculosis bacteria, which is the Mycobacterium tuberculosis, your skin will react to the antigens by developing a firm red bump at the site within 2 to 3 days. Also, you can use the interferon gamma release assay, which is a test that measures the release of substance called gamma interferon by white blood cells in a sample of blood when the cells are exposed to specific tuberculosis antigens. The interferon gamma release assay is only done as a screening test or during contact investigation. And when available, there is also the nucleic acid based testing. Treatments for active tuberculosis: you can take antibiotics for at least 6 to 9 months in this scenario. If you have latent tuberculosis, you may need to take only 1 or 2 types of anti-tuberculosis drugs. The most common medications used to treat tuberculosis include isoniazid, rifampin, ethambutol, and pyrazinamide. If you have a drug-resistant tuberculosis, a combination of antibiotics called fluoroquinolones and injectable medications such as amikacin and capreomycin are generally used for 20 to 30 months. Thank you for listening to my tuberculosis presentation. I hope you were able to understand and get some information about this disease. Thank you. Have a good day.